think we are ready to get started. So good afternoon, everyone. My name is Anna Duncan. My pronouns are she, her, hers, and I'm a program operations specialist here at CoLab for Community and Behavioral Health Policy and the Evidence-Based Practice Institute. On behalf of our team, I want to say thank you so much for joining us on this Friday. This webinar will explore the 2021 Washington State Reporting Guide for Evidence-Based Practices in Children's Mental Health. We'll start with a land acknowledgement. CoLab for Community and Behavioral Health Policy and the University of Washington acknowledge that we gather on Indigenous land, the traditional territory of Coast Salish peoples, and specifically the Duwamish tribe. This ancestral land is unceded and must be returned. We also acknowledge that our work across the state takes place on the homelands of Native peoples who have lived in this region from time immemorial. Currently, there are 29 federally recognized and 7 non-federally recognized tribes within Washington state. We express our deepest respect for and gratitude toward these original and current caretakers of the region. As we move forward in advocating for and moving toward health and racial equity, let us remember that we're living in a history-driven present. Work to learn more about histories, cultures, and traditions of Indigenous people and how we might build relationships with sovereign tribal nations and create more inclusive spaces that foster innovation, collaboration, and empowerment. We encourage you to consult nativeland.ca to learn more about the land that you're on, and also to pay rent through Real Rent Duwamish. The Duwamish tribe has yet to be justly compensated for their land, resources, and livelihood. And by paying real rent, you can do something today to stand in solidarity with First Peoples of this land. All funds go directly to Duwamish Tribal Services to support the revival of Duwamish culture and the vitality of the Duwamish tribe. And please see the links in the chat for more information. All right, I'm ready for the next slide, please. So before we begin, I'd like to do some Zoom housekeeping. So if you encounter any technical issues during the webinar or just want to express general thoughts or reactions to the speakers, feel free to send us a message through the chat box, which is highlighted in red below. So we welcome, general reactions to the content. We want this to feel like a collaborative space. We will have a Q&A session after the presentations, however. So we ask that if you have a specific content-related question, you put it in that Q&A box down below, which is highlighted in purple. And so we won't be pausing between presentations to answer Q&A. We will answer all questions at the end. And as a reminder, we will be recording this webinar and we'll be uploading it to our website. Next slide, please. So at the end of this webinar, we will send an evaluation survey link through the Zoom chat. So please fill it out with any feedback you have so we can improve future webinars. We'll also be sending an email out with this link to the survey and the recording as well, in case you want to access those through that email. In the evaluation survey, we also encourage you to share additional topics that you might be interested in for future webinars. All right, next slide, please. So before we begin our presentations, I just wanted to take a brief look at the poll to see who's in the virtual room with us. So it looks like we have a large number of mental health care professionals, which is no surprise given this topic. And it looks like also a number of folks in advocacy, policy, healthcare research, and the medical field. So it looks like, by and large, mental health providers, which makes a lot of sense. So thanks all so much for being here. And now that we're done with the logistics, we'll jump into the content. Wonderful. So again, I want to thank you all so much for being here. We at the CoLab for Community and Behavioral Health Policy are really excited to host this webinar. As previously mentioned, today's webinar will provide an overview of the updated 2021 reporting guide for evidence-based practices, or from here on out referred to as EBPs, for children's mental health in Washington state. And my colleague Maggie will put the link in the chat to our current reporting guide in case you want to reference it throughout. And for those of us who may have not heard of us or are joining us for the first time today, the CoLab for Community and Behavioral Health Policy was founded in 2020 within the Department of Psychiatry and Behavioral Health Sciences at the University of Washington. The CoLab engages community expertise and research evidence to spark creative and sustainable change in behavioral health policy and systems, particularly those involving youth and families. We believe communities and systems have deep knowledge and expertise that must be leveraged to promote effective, sustainable, and impactful community programs. Additionally, the Evidence-Based Practice Institute, which you've also heard mentioned, is an organization that's housed within this CoLab organizational umbrella. And it was established in 2007 by the Washington State Legislature to promote high quality mental health care for kids and families. If you're interested in watching other webinars we posted or generally learning more about our information and our work, please visit our website at uwcolab.org. So now on today's content. For today's webinar, we're excited to feature five different panelists who will be speaking to different aspects of the reporting guide. So Dr. Sarah Walker will start off our presentations today. She's the director of CoLab and the Evidence-Based Practice Institute. Then I will go on to share updates to the 21 version of the guide. Justin Daignault will present on using EBPs in the real world. Dr. Georgiana Sedlar will present a case example, and Maggie Fenwood Hughes will discuss the back-end reporting processes. So with that, we're going to move on to the next slide, and then we'll start our presentations. So before we start with Dr. Sarah Walker as our first speaker, wanted to provide a brief overview of our guiding principles for quality care and to discuss the complexities of EBPs and their history. So here at CoLab and EBPI, our guiding principles for quality care include evidence-based, culturally responsive, and client-centered care. So we name these today because culturally responsive and client-centered care are often seen as at odds with evidence-based practices, or EBPs. EBPs have a complicated history, and there's understandable distrust of them as a modality of care. Many EBPs were developed using data that's not representative of the population at large, with many studies lacking critical representation of BIPOC and other historically excluded populations. Further, many manualized EBPs are considered to be too rigid and inflexible, unable to adjust to the client's culture, needs, and preferences for care. So with these critiques, EBPs really bring up questions such as, how do we define evidence? What context and whose voices and experiences were centered in the development of these programs, and whose experiences were and continue to be erased? We highlight these challenges because they're an important part of the conversation around how we define quality care, and is something that we continue to navigate as an organization that centers all three of these values. So our fundamental goal is really to increase the effectiveness of care provided to kids and families in the Medicaid system, one which we all know is under great strain right now and serves the highest need and often lowest resource families in our state. So the big question we're hoping to answer here is, how do we develop effective services backed by research and evidence that actually facilitate true healing for folks within the behavioral health system, which is a system that has already existing payment models, big time constraints, high turnover, and huge caseloads. So throughout this webinar, we'll touch on how our components model of EBPs aims to bridge our core values by promoting more flexibility, responsivity, and client-centered approaches to EBPs. So with that framework, I'm going to hand it over to our first presenter and our director here at CoLab, Dr. Sarah Walker.
Thank you so much, Anna. It's great to be with you all today. I'm just going to do a few framing comments as an introduction to this webinar. We've got a lot of content to cover. Just want to say we're super excited to present some of the updates to the reporting guide. A lot of effort has gone into making the guides more user-friendly, more clear, and more reflective of the values that Anna just covered. So we'll go to the next slide. So as most of the folks here in this webinar know all too well, mental health need is now the leading cause of illness and disability for children and youth worldwide. Here at EBPI, we do a lot of work to cull the scholarly literature, and it's pretty clear that despite the variety of philosophies regarding effective treatment in the mental health field, some treatments do appear to outperform others in how rapidly they help clients recover from distressing symptoms and how effective they are in sustaining long-term recovery. Next slide. In addition, a critical element in mental health treatment is ensuring delivery is culturally responsive. This is true for ethical reasons, and it's also an evidence-based approach. clinicians who are more culturally responsive or using more culturally responsive protocols see higher rates of engagement and completion and outcomes in mental health care. Next slide. So at EBPI, the reporting guides, the way we define them and monitor them are trying to reflect both of these critical aspects of care, paying attention to what new discovery and new science is suggesting will be maximally beneficial and helpful to youth and families, while not losing sight of the incredibly important delivery modalities and the client-centered approach to care. So as we're going to talk about in terms of monitoring, we've adopted a core components model for defining and monitoring care, and with the purpose of supporting clinicians to be flexible in their approaches so that they can respond to the cultural needs and preferences of their clients. Next slide. There's a couple reasons that we collect this information in collaboration with the healthcare authority and payers in our state. It helps the state understand the quality of services and the distribution of those services across networks of care, which help to guide investment and also help to guide technical assistance and support activities. It also allows our research partners to look at important aspects of care like disparities in client satisfaction, the relationship between the type of treatment delivered and outcomes in a real world system. Next slide. Washington State is one of only a few states that even attempts to track the type of treatment being delivered to clients in routine mental health visits. And we're the only state that's managed to track this exclusively through claims data with no additional reporting asked of providers. Next slide. Oh, previous slide. The guidance for reporting was specifically developed to be fully verifiable through medical records review. At the same time, we recognize that setting up the processes to train and track whether EBPs are being reported is still a very heavy lift for provider organizations who are stretched just to meet the requirements and demands of providing care. So we want to acknowledge that and really genuinely thank the organizations that have taken this on. It's a huge help for state strategic planning and our ability to know who to reach out to help support implementation of quality care processes. And then please know that our team is eager to partner with any site to answer questions or be a support to you as you go through this process. So I'm going to turn it back over now to Anna Duncan, who's our project operations specialist and project lead over the reporting guides. Thank you.
Thank you, Sarah. So as Sarah mentioned, my name's Anna and I'm a program operations specialist here. I know I already introduced myself, but I'm now going to be providing a brief overview of what has changed from our 2020 guide to our 2021 guide, which is our current and most updated version. So can we go to the next slide, please? Thank you. So I first want to just provide a brief update and kind of overview of our components model, which Sarah just mentioned. This has always been our approach, but I know that some folks may be newer to this model or newer to the guide. So we just wanted to cover this as kind of a baseline before jumping into more content. So the goal, as you can see, is to really identify evidence-based components of a treatment rather than requiring a rigid, inflexible, manualized treatment that doesn't allow for clinician judgment to determine best course of care. So the components model really aims to be flexible, used at the client and clinician's discretion, and really allows space for client-centered and responsive treatment approaches. So in order to develop the components model, we've worked with content experts to identify what we call the active ingredients or essential elements of a treatment. And these are the elements that are empirically shown to be the primary mechanisms for change in a particular treatment approach. Next slide, please. Could you try to click one more forward? I think, yeah, oh, perfect. There's an unexpected animation here. Would you click one more time, please, Joanne? Thank you so much. So then, just to provide an example for what we mean by the components model, when we're thinking about, for example, the treatment CBT for anxiety, we worked with content experts to define the essential elements, which are exposure, and then if you can click one more time, thank you, and then cognitive restructuring. So these are really the active ingredients that distinguish CBT for anxiety from other types of treatments for anxiety. Each of these ingredients or elements, as we call them, is supported by the evidence base, but are meant to be employed flexibly with the clinician's discretion. So the reporting guide instructs providers on how to document their use of these evidence-based clinical elements as part of a full treatment approach. And as you can see here, the components model also includes something called allowable elements for each treatment family or treatment approach. So these aren't necessarily the primary mechanisms for change, as are the essential elements, but these are kind of additional evidence-based components that can be used to support a client within that treatment approach. So for example, if you're treating a client with CBT for anxiety and are using exposure as the main kind of therapeutic mechanism for change, things like motivational interviewing, psychoeducation, or cognitive coping can be additional evidence-based components to support with the efficacy of your treatment. And by identifying these components, rather than adhering to kind of a step-by-step, more rigid EBP approach, our aim, as I mentioned before, is really that clinicians and clients can collaboratively work together to find the best course of care while still using evidence-based practices. And again, we will discuss this more later on in the webinar, but a clinician should be using at least one essential element and then one allowable element in their treatment plan and treatment notes for working with a client. All right, next slide, please. Thank you. So I did want to share a little bit about our process for how we update the guide each time. So with this last update from the 2020 guide into the 2021 guide, we really aim to incorporate input from all different types of folks within the behavioral health system to ensure that our work is grounded in user experience and is as applicable and accessible as possible. So for this 2021 guide update, we interviewed 9 behavioral health clinicians and supervisors from across Washington State on how they understand and use this guide. So this helped us get a sense of what needed to be clarified, what needed to change, and what was working well. So again, as you can see in this diagram here, we held these interviews and then coded them for themes and major changes, made updates to the guide, and then sent it back to folks for final review before publishing the guide. So our goal here at CoLab and EBPI is really focusing with a user design centered approach to ensure everything is applicable, accessible, and relevant. Next slide, please. So just to highlight a few of the results that came out of our user design process. So perfect. So first, we developed the glossary with key definitions. We also developed a reporting process flowchart to help kind of guide clinicians and supervisors on the EBP reporting process. We developed specific clinician and supervisor resources and linked them within the guide. We developed an appendix with training resources and information. And we developed the guide and restructured it so that it's aimed based on user type, so that it's easy to identify where the information is for you as a specific user. We also removed uncategorized training entities. And we added more treatment families that you can report on. And next slide, please. So then to cover kind of the 2 major changes we made to the 2021 reporting guide. Next slide, please. So in our 2021 guide, we included a categorization of generic versus name brand EBPs. So for example, the generic version was CBT for anxiety, and then name brands could include Coping Cat or From Timid to Tiger. And as you can see, there are a lot of animal themed anxiety treatments. So in an effort to really standardize the components model and to increase flexibility around EDP use and reporting, we just took out this distinction in the 2021 guide. So now everything is reported under the general umbrella treatment approach, which we call the treatment family. So examples of treatment families include interpersonal psychotherapy for depression or CBT for first episode psychosis. And just to clarify, and we'll talk about this more later, a treatment family is really just this collection of individual treatment approaches that use those same core elements. Next slide, please. The last thing I want to touch on is that in this 2021 guide, we really expanded the number of treatment families or treatment approaches that you can report EDP components for. So it includes CBT for first episode psychosis, CBT for OCD, adolescent family systems therapy, treatments for eating disorders, treatments for ADHD, and treatments for significant mood disorders and self-harm. So these are really our big changes for the 2021 guide, and I will now hand it over to Justin for the next portion of our webinar.
Great, thank you, Anna. Yeah, so welcome everybody, glad to be here. So who am I? Why am I here? I am not necessarily part of CoLab, but I'm a consultant. I am a clinical supervisor and clinician at Youth Eastside Services in Bellevue, Washington. And I use this guide in training staff in my own clinical use, and I've helped with updating this version of the guide. So I'm going to talk about how I use and would recommend using the EDP reporting guide. Next slide. So as Anna mentioned, there's this kind of handy flow chart, which is on page 12 of the guide. So if you click that little link at the beginning of the webinar, you can kind of follow along a little bit here as well. But this is kind of a landing page for me because, again, the guide is quite a hefty, comprehensive guide, I'd say. So coming to this gives a nice kind of overview and flow of all the parts that are included in this guide. So I kind of see this as a cheat sheet a little bit. And again, page 12, if you want to reference it. There's also reference pages for each treatment family, as Anna mentioned, and I'll talk a little bit more about that next as well, but that's a key area in each section of the guide clinically to reference as I'm going through treatment or beginning treatment or planning treatment with clients, or as I'm talking about it with my supervisees. I would also recommend generally, where you're going to keep this guide. So it lives online, but you can download it and keep it in your own internal files. So I have it digitally for all my staff to reference. And during trainings, you can also print out the different sections that are useful for different people, such as those treatment family pages, because they're only 1 or 2 pages each. So they're pretty easy to pull out and use. The last kind of overview I want to start with here is, again, this is for the purposes of reporting EDPs. So if you're using EDPs, report it. And hopefully this guide will help you with how to do that accurately. And if you're not doing EBPs, don't say you are, right? Trying to figure out that accuracy piece and how this guide can be helpful for you, and leaning towards the use of EBPs for all of our clients, and making things more accurate and effective in our systems, ideally. All right, next slide. Thank you. So here I've included parts of that anxiety treatment family section. So again, each treatment family has a different kind of area or section, couple pages. This is just one snippet. So you'll see where it says cognitive behavioral therapy for anxiety, and then it gives a little description of that family. So each one has their own page. And it also then underneath has those clinical elements for treatment, essential clinical elements for the treatment plan, and then allowable clinical elements for progress notes. So again, these are those really great kind of, again, cheat sheets or reference points for clinicians and for supervisors to go through to figure out those details, to see a little bit of client-friendly language and descriptions for some of those interventions. So this is the best reference point, I would say, in the guide for me clinically to help kind of direct that use of EBPs, the language we're using, and the consistency piece. All right, next slide. So starting with this kind of clinician lens, if you are a clinician in the room, just thinking for yourself, going with what you know. What training do you currently have? Are you new in the field? Have you been in the field quite a while? Are there opportunities to get further training externally or internally to your agency that you're at or in your practice? So that might mean talking to your supervisors for support regarding future opportunities. or ones that are part of agency expectations. Like our agency, we kind of try and get everybody trained up in things like CBT, DBT, motivational interviewing, TFCBT, some of those evidence-based practices. So we have kind of that trajectory for our staff from hire, or if they already have that training from before of how to support them. So is there a way to get that training or be supported and get it approved by work if it is an external training or not set up or established by your agency themselves? The next piece is like, are you being supervised by someone that's also trained in that modality, or can you be, right? So this guide can help show you what trainings might be out there and connect your agency or you to what those training entities are, if you are or are not already connected, right? So if you're not trained and not supervised in that modality, again, that accuracy piece, maybe don't use it if it's out of that scope of practice and outside of your training. So maybe don't say you're using EBPs, but that might be a next piece of you're already maybe using those elements, or maybe from graduate school, you've got training in some pieces. So again, leaning towards what is that active training that you can get moving forward to claim that you are using those evidence-based practices and allowable elements. Can you collaborate with your peers? Perhaps there's consult groups or group supervision around those EBPs as well at your agency. Those are great things to connect to as well. So this guide can also help you find language. So around the structure and direction of treatment, right? So drafting treatment plans also, and you'll see here is ISP, individual service plans. Some places call them different things. But this guide can help form a baseline to bring with you to all your sessions to clients. And that's where you can then incorporate client voice and some of those, again, suggestions in the guide for client-friendly language. So you can kind of draft a little bit of a treatment plan based on some of the targets you're seeing from what clients are bringing in or from that intake and the diagnosis. And this can kind of help direct what kind of language, what kind of elements you're going to be using even before you are doing the elements themselves, right? You want to plan ahead as much as possible over the course of treatment. So assessing for and identifying those clinical targets or diagnosis, and then that recommendation of, are you recommending EBPs or not, right? How are you documenting that? What are your targets? Setting session agendas based on those goal-directed outcomes. So all those things can kind of line up from day one, and I'll kind of show that in another couple slides, a little bit of the flow of treatment. But I really find this is very useful for providing some direction and guiding that recommendation to maintain evidence-based practice use. It can feel a little bit, I think with my clients, reassuring of me as a practitioner, a little bit of confidence for me, because you can say, oh, I'm doing these elements and they're linked to this EBP and I'm trained in it and I'm getting supervision around it. It all should build this kind of, again, golden thread through what you're bringing into sessions and what the feedback is you're getting from your clients, if it's working or not. So I think, again, from day one, having something you can present with some of this language in it to say, hey, this is the EBP and let's start with this. And it can be flexible based on clients' needs, but it really has a good baseline starting point for most treatment plans, or again, individual service plans, I find. All right, can we go to the next slide? So another question definitely to think about is what electronic health records, so that's the EHR here, what electronic health record systems are you using, and how are you documenting things like narratives or evidence-based practices in those kind of clinical records? And again, not all systems are created equal. Some are clunkier than others, some are not as user-friendly, some are very clear. So just making sure you know how to use your EHRs and you're trained in them. I'm going to mention a little bit of DAP or SOAP notes here, and Georgiana's next going to cover a little bit of examples. So I just want to touch on this a little bit briefly. But that first area, kind of description or subjective or objective area. So again, check with your supervisor how evidence-based practices get documented beyond progress note narrative. For us, we have checkboxes underneath our narrative. So we have justification of like, what did we do? How did it go in session? All those pieces. And then down below, we have checkboxes of which EBPs we actually used. And that's where some of that links to the codes that are going to be used, which will also be covered a little bit later. The assessment of your notes, right? That's where you're maybe doing evidence-based practice assessments, right? Getting some of the targets, getting some of that diagnostic criteria, what you're hearing from your clients, and then that feedback loop. So what's in your treatment plan and how's it going in session? Those things should help inform one another of what's the response from client. And that's going to justify any changes you need to make to your evidence-based practice. The plan section, what the therapist and the client do before the next session, right? So review at your next appointment. Did those things happen? That's again a piece of consistency and follow through with things like homework, or again, those evidence-based practice links, golden thread throughout the treatment. All right, next slide. So I wanted to give a little bit of a flow chart here. Again, I mentioned some of these pieces of golden thread, and so we'll just kind of walk through a little bit of how I see treatment and how I train, how I've been trained and how I use training with some of my clinicians. So this is again like a kind of simplified, I'd say, treatment flow chart from all the way from intake to exit, and where EBPs come in handy, where this guide comes in handy to use. So we first start looking at the intake. So here, ideally, there's an original assessment completed to determine targets and diagnosis, things like strengths and barriers. We also use things like social determinants of health for whole person and system-based perspectives, in addition to other recommendations like medications, groups, other services. So you're going to get a lot of information depending on how your system is set up, right from that initial intake from the client of why they're coming, right? What are they identifying as the problem and what are their needs? Because we're going to match that with evidence-based practices of how we can help them. Next slide. So from the intake, again, and then in those first few sessions, for us, we have 30 days to kind of complete our first individualized service plan or treatment plan. You know, how are you formulating that treatment plan to determine the direction of services? What are the recommendations for treatment? Many of those, again, targets or diagnosis, you can link directly to that EBP, again, like a treatment family that you're going to then look at the evidence-based practice guide and say, oh, this client's coming in with something like anxiety, and these are the symptoms, and we did an assessment, and it really lines up well. You know, if we're recommending that evidence-based practice, we have it right in alignment there, alongside, again, the guide, kind of following and tracking what the guide is recommending to us for those interventions. So you're taking, again, in that information from the intake, as well as any new information you're hearing from the client or other reporters, things like, again, systems, school, parents, doctors, other guardians, to formulate what the needs are, what those goals are, and then matching those interventions that you can actually provide, again, based on your training and supervision. You're utilizing client strengths and culture to establish the plan, and the evidence-based guide is going to be really useful here for those treatment families, matching the target to the symptoms. Again, making a fairly comprehensive plan, even from day one, again, building that confidence for new clinicians, I find, and as a supervisor to help guide and supervise along the way. Go to the next slide. The next piece is ongoing treatment. So you can see this kind of double arrows that kind of go back and forth to communicate with each other. So as you're carrying out your plan with your client, are you doing what you said you were going to do? And is it working? So you should be getting feedback live throughout your sessions, and the content of the plan. Is it helpful? Is that determining updates? So again, this is where you're documenting DAP or SOAP notes in your EHR. And if things are successful, you're getting that feedback. That's great. Keep going into those goals or those treatment that you're reaching kind of those end targets, and the reduction of symptoms. Or again, it's giving feedback to saying, actually, this isn't quite working. Maybe we need to tweak something or modify something. And let's go back to that treatment plan to make some modifications or changes. Again, as targets change, as assessments change, those types of things. Next slide. And then that last piece. So here is, you know, if you're determining goals are being met and target or symptoms have been reduced, that's a great time to look at that vacation or discharge from services. Ideally, that clients maintain those goals for a little while and generalize treatment to a lot of, again, life domains or environments, different settings. So again, this is just kind of an overall condensed snapshot of a treatment cycle and that connection of elements from intake all the way to discharge. And this is kind of where that EBP guidance comes into play for me. All these different, you know, each area focusing on that diagnosis and targets, that treatment plan, and that feedback with the client. Those are really key elements. But the guidance and the baseline can really come from this guide, I find. Next slide. All right, shifting a little bit now towards supervisor lens. I definitely wanted to point to another guide, so a guide within a guide here a little bit. I would like to point to the CBT Plus Collaborative Organizational Practice Guide from 2013. That you can find actually at the bottom of the EBP reporting guide. There's a resources section, and this is in there. So, and again, this is also another large document, so there's not time to kind of cover all those pieces, but I'm going to cover a few pieces that I find really relevant. And again, I would have you reference that more comprehensive guide as well after this. Some of the first pieces, connect as a supervisor, connect to your clinicians, right? Find out what their training and their background is. Again, upon hire, you should be kind of knowing that or asking those questions of knowing who you're hiring, what their background and training is, who's training EBPs, and then linking things to like, what's the gap, right? If you have a lot of people that are not training EBPs, do you have a guide or a plan within your organization to actually get people trained up in EBPs? Is that an organizational goal or trajectory or maintenance that you're doing? Do you have a training point person or a team that looks at trainings and evidence-based practices and the monitoring of that? So you're going to have the agency support. Clinicians can't do it by themselves. They can kind of like, squeaky wheel, be like, hey, I want this training. Hey, there's this outside training, but it's not going to happen on a larger scale, especially when there's a need for support for staff time, and that equates to funding. And all of these things are also not free for training time too, right? So this is going to mean there's a priority set each quarter, some kind of cycles or annually around funding and budget that supervisors or leadership will need to have some buy-in for in order for this to be a sustainable process within a kind of cohort with hiring or amongst all of your staff that you have already. So if you're not connected to EBP's training, those active entities, again, you can actually find those lists in each section with the treatment family. So I put a little snapshot here of that where it shows the training entities for just a couple of those for the CBT for anxiety area. But each section has that, where as a supervisor, you can look at that and say, hey, are my staff trained in these, or can we connect to those entities to get some training to set up and inform that organizational plan or training plan you may have. That next piece is going to be, ongoing support and supervise clinicians. So through the training process, do they have someone to lead them through that at your agency side? Because you're going to have a little bit of support from the trainers, but how is it implemented and used in your agency? And again, how is it being reported? How are you training people how to report things on the implementation and the clinical actual application of the principles? Do you have your own training in EBPs, right? So are you sending clinicians to trainings that you actually are not training yourself as a supervisor? So how are you going to supervise along those EBPs? You likely would need to go get that first, ideally, or if you already have it, that's great. Kind of lead the charge there. But what is your own experience, your own expertise to facilitate that practice and learning of other people at your agency? Can you form, again, those consult groups, group supervision, that connection to internal, external providers or trainings? That's going to be really supportive of a longer process rather than a one-time training that then falls off after 1 year or annually. So get feedback on trainings, implementation, ongoing opportunities. What else is out there? Other agencies, what are they doing? Do you have those contacts? And then lastly on here, supervisor support. So maybe you need extra support for training, right? Maybe you're the only one training that EBP and you'd like to get other supervisors or leaders supervised in it. Do you have a peer group or a supervision of supervision available? Those might be really supportive things as well. Next slide. All right, so making sure your EHR is actually reporting what you think it's reporting. We've had an issue with that ourselves at our agency, and those check boxes, making sure they're actually on the back end, somebody is following up with CoLab with EBPI here. Again, we can touch on how to make contact later, but are you training your staff on procedures? Are you closing that loop of training staff on it and then actually using it and supervising and seeing all those notes? And are people routing notes to you as a supervisor? And then you're checking all those elements. Again, in the EBP guide, you can actually see the language that clinicians are using. Are they following the guidance? And checking those components are there and matching that diagnosis, that golden thread all the way through treatment. That's kind of what you are monitoring as a clinical supervisor, all the way from that intake to exit again. How is the organization system supporting you as a supervisor and the clinician in effective use and reporting of EBPs? Maybe you're already using EBPs and reporting them. That's great. Keep doing it. But how do you maintain that, right? Again, what's part of your plan? What's been challenging? What's working? How do you assess and maintain that? And if you're thinking about next steps of EBP reporting, maybe you're not quite there, or your EHR is not really that effective or not able to report right now. What are the barriers? What could you be doing? Are there missing pieces? Again, other players or other agencies you can reach out to, the CoLab or EBPI, on how to make that happen. Personal suggestions, and just be thinking about what supports are needed at your agency, and who are the key players in helping make that successful. So I'll kind of stop there, and I want to pass it on to Georgiana for some examples as well.
Thank you so much, Justin. So great to have you here. And I say you are an honorary member of CoLab for sure. Justin has just been so hugely integral to so many different initiatives and projects we're working on. So honorary status for Justin. I'm Georgiana Sedlar. I'm an assistant professor in the Department of Psychiatry and Behavioral Sciences here at the University of Washington. So I work with Sarah, Anna, Maggie, Joanne in CoLab, and I also am a core trainer and consultant for the CBT Plus Learning Collaborative here in Washington State that some of you on this webinar may have participated in or heard of. My training is as a child psychologist, and so I've a lot of my professional activities right now focus on supervision, training, teaching in evidence-based practices, and particularly cognitive behavioral therapy. So I'm going to just take a little bit of time to walk through an illustration of what this might look like from what Anna and Justin and Sarah have already shared. So the next slide, please. All right, so here's an example. We have Hannah Helper, a therapist at Doing Good Agency. She's been assigned to start therapy with a 15-year-old female client. And so Hannah Helper, she, her, hers, is doing the intake assessment and found that this client, this 15-year-old female, is reporting low mood, their sadness, isolation, not a lot of interest in things that she used to enjoy, like spending time with friends, singing in her choir, dancing on her school's dance team. And so this intake assessment, Hannah Helper, being the great therapist that she is, draws upon both standardized assessments as well as interviews with the client and collateral sources. So based on this, the clinical problem or target is depression. So if we could go to the next slide. And so again, Hannah Helper, being the great therapist, the competent, wanting to be an effective therapist, looks to see what will be an evidence-based, evidence-informed intervention for addressing the clinical target of depression. And so decided that CBT for depression will be the identified intervention. And then the next slide. And so Hannah goes to the reporting guides here for CBT for depression. And you can see there's a treatment family description. This is just a screenshot. And Hannah goes to the training entity list and sees that, in fact, the training she received through the Harborview CBT Plus Learning Collaborative is an approved training entity. And so therefore, that particular checkbox can be checked for her to be able to report EBPs moving forward. As you can see, there's other training names listed on there. I'm just sort of highlighting one of them for this example. And then if you can go to the next slide. So, you know, Hannah Helper is going to write her treatment plan. This is just a template. This is just something as a kind of a visual. This is not at all meant to be, this is the one that people should use. So let's go to the next slide to kind of walk through what a treatment plan might look like for this particular client that I've been talking about. So I've been using treatment plan, but as Justin also noted, you know, some of you may call it individualized service plan within your organizations. And again, this is just some language just to, again, illustrate how you might incorporate those essential elements into a treatment plan. So here Hannah Helper has noted, you know, that she's going to provide psychoeducation. So that's great. That's an allowable element. It's not considered an essential, but I love to see that. I think psychoeducation is a common element that's important in a lot of different evidence-based practices. Going to use coping skills, using mindfulness, relaxation skills, based on, you know, sort of clients' willingness to engage in that and to try it. Again, that's allowable element, but you'll see items 3 and 4 on the treatment plan, and I've highlighted to really have people hone in on these are the essential elements that are at least one essential element needs to be on a treatment plan for it to be eligible for, you know, counting as an EBP for the reporting guide. So here, this therapist is going to use behavioral activation, which is really an active ingredient for CBT for depression, to improve her client's mood and, you know, the client's expressed desire. So there's some of that client voice that she wants to be more active and engaged in life. And then the item 4 is another, so behavioral activation is an essential element for CBT for depression, and then cognitive restructuring is another essential element. So the Hannah Helper here noted that that's also part of the treatment plan to reduce any depressive thinking that this client might have that's contributing to her depressed mood, and then drawing upon sort of client's interests to help with implementing cognitive restructuring. So if we could go to the next slide. So Justin mentioned both SOAP and the DAP note, which I know again is both of those formats are commonly used in behavioral health organizations. So I'm going to walk through sort of again, pulling this example from intake to the treatment plan I just covered to this progress note. Again, I'm just showing this visual. This is not like this is how, you know, your organization's note should look. It's just to remind people, again, the acronym that SOAP is subjective, objective, assessment, and plan. So I'll kind of walk through that in a little more detail. So if we could go to the next slide. So subjective is the client's perception, you know, of their difficulties, their challenges, and what is told to the provider. The client's mood rating for this week was a 7 out of 10, and the client stated, "I can't get up in the morning, which makes me late, and then my mom gets on my case." And client continued by saying, you know, "There's something really wrong with me, and my parents don't understand what I'm going through." So there's that client's perception and the client's perspective on that. And then if we could go to the objective section. So the objective part of a SOAP note is the provider's observation or information from other sources. And this can include use of standardized measures, which again, measurement-based care is highly encouraged and an allowable element. So even though I'm honing in on psychoeducation, as you can see here in this example, that they're also using measurement-based care to inform their decision making. And as Justin talked about, you know, giving feedback is so important, talking to clients about that, and also using it as a decision making as you're doing treatment to make sure, are you on track? Do you need to shift? is it time to graduate from treatment? So here's, this includes the provider's observation that client's affect was blunted and they looked down at the floor for most of the session. And the objective part can also include sort of what a clinician did. So provided psychoeducation to client regarding depressive symptoms, its impact in communities and on families, and provided statistics and data to normalize and give context to client. And then measured client's progress or improvement in depressive symptoms with the PHQ-9. And then the score was 17. Still, again, this is early on in treatment, right? So moderate severity, but had decreased 2 points since intake 2 weeks ago. So this is sort of kind of an initial session progress note in the early stages of treatment. Let's go on to the next. So for assessment, this is a summary of the subjective and objective sections, and a summary of clinicians' thinking about the chief complaint. For some organizations, it may also mean that they include the diagnosis and response to treatment and the client's response to treatment. So, here they're noting that the client meets criteria for major depressive disorder, and then including sort of how client responded to being provided psychoeducation. That it sounds like, I didn't know that many people had depression or that it can show up differently in families. That's helpful to know. So again, including that client voice and sort of how they responded to receiving that information. And then can we go to the next slide? So plan is a clinical action plan, can also include prognosis, as well as sort of planned homework elements for the next session. So here, introduced the idea of mood versus goal-directed behavior and provided information to client on how depressive symptoms are maintained. So that's sort of a setup to behavioral activation. They introduced behavioral activation. Again, I've highlighted that to show that's the essential element being delivered. That was introduced to client as a way to reintroduce pleasurable activities into their daily schedule to improve mood. Discussed plan for client to identify one pleasurable activity to do each day for 15 minutes. Client will rate their mood before and after. So again, that's what they're going to do before next session. And the plan can also include sort of coordination, which is good, just clinical care. So they're going to contact the client's medication prescriber to discuss their response to medication. If you can go to the next slide. So now I'm just going to go through DAP as well. You'll see some similar, you'll see a lot of overlap. I know some people use DAP instead of SOAP. And again, I think there's a lot of similarities. So this is just a graphic. If we can go to the next. So again, this is, data for the DAP is both a combination of subjective and objective. So you can see here, I just, that this example includes the psychoeducation component, which is an allowable element under CBT for depression. We can go to the next slide since I already showed that in the earlier SOAP note. And again, then assessment is akin to the assessment part of a SOAP note. So you can see here that the information about the PHQ score and also the client's response to their being provided psychoeducation in that particular session is noted here. And next slide. And then again, the plan, much like the plan in the SOAP note, the use of behavioral activation as a essential element. And then I think I'm turning it over. Yeah, so there is an example. I saw some things come up in the chat, which wasn't able to sort of talk and address at the same time, but I'll take a look. And if it wasn't addressed, we have reserved time to hopefully get your questions answered. So I'll turn it over to my colleague, Maggie Finwood Hughes.
Thanks, Georgiana. Hi, everyone. I'm Maggie Fenwood Hughes. I am CoLab slash EBPI's research manager and relatively new to the team as of September. So I'm just going to kind of bring it full circle, and I won't take up too much time, but just going to talk a little bit about how we are using some of the data that we receive from HCA on reporting of EBPs. So since I started, part of my role has been related to collecting and distributing quarterly EBP reporting data that we get from HCA, and this is an effort to make these data more transparent to providers, payers, and other partners. So we publish this on our website. And the hope is really to inform and improve reporting processes and kind of use the data ultimately to contribute to promoting and using quality care practices. So next slide, please. So we summarize and share data we receive from Washington State Healthcare Authority, which details EBP reporting activity across the state. Currently, we release these tables through our listserv and on our website on a quarterly basis. And we have focused on county level data, as well as kind of just showing the number of agencies reporting EBPs. But there's a lot more detail we have access to and various ways that this data could be analyzed and interpreted. So if providers and agencies are interested in learning more, we have additional data to share. So if you want to know your EBP rate, get in touch. And on the next slide are just some recent examples of like the last quarterly data report we put out. So that's just to kind of familiarize yourself with what we share right now. Great, so next slide. So I think Justin kind of went through this a little bit already. There are some tailored processes for EBP reporting that can be developed in your electronic health record system for documenting in session notes and treatment plans, but they can also be set up to transmit reported EBP codes as part of routing billing data to manage care organizations. So that's kind of the more technical sort of back end side of things. And as you can see on this slide, we have kind of the technical steps for reporting EBP codes that begin in 860. And we have found there's some misalignment. So on the next, if you can go to the next slide, we are planning to kind of bring the mental health billing guide and the SERI guide into better alignment for reporting 870 and 860 EBP codes. So we did receive some of that feedback from partners that we've worked with. So stay tuned for that. That'll be released in the next mental health billing guide. So if you can go to the next slide. Am I still coming through okay? Sorry, I think I saw myself kind of freeze. Okay, great. All right, so just to kind of wrap things up, our hope is to kind of create, what we would call, sort of a learning health system. And bringing back to what Sarah touched on at the beginning of the webinar is we really want to inform a feedback loop for providers and payers and state partners to learn from and respond to data in real time. So we want to hear from you and use your input to understand where there are disconnects and gaps. And through developing kind of this mechanism, we can integrate internal data and experience with external evidence to drive improvements that can impact care, improve quality within our organizations, and then of course contribute to improving overall population health. So for our scope of work for next year's EBPI contract, we really want to focus on further understanding the landscape of care and developing a model for sharing and learning from each other so we can create a community around this to better inform treatment practices and ultimately for the benefit of the clients and populations that you serve. So that's all for me. I'm looking forward to hearing questions and for the discussion. Thanks, everyone.
Thank you so much, Maggie. So before we transition over to Q&A, just wanted to share our contact information. So the UW CoLab at uw.edu is our organizational email. So we monitor that daily. So feel free to reach out. As Sarah mentioned at the beginning of this webinar, we would love to field questions and also are happy to meet with you to kind of provide additional support around this topic. And we've also included Justin's email as well.
Anna can, oh, there you are, great. And I was just gonna try to fill in for you if you were frozen, but it looks like you're back online.
Oh, okay, great. Sorry for hopping off there for a moment. So I was just saying that this is our contact information, that you're welcome to reach out to either us or Justin with any additional questions. All right, if we can go to the next slide. So additionally, I just wanted to highlight again where you can find our guide. So you can find it both on the EVPI website and then also the CoLab website as well. And we will send out these slides with links as well, so you'll have access to those. All right, and now if you want to go to the next slide, please, Joanne. We'll now pivot to the Q&A portion of the webinar. So I know that we saw quite a few questions come through in the chat. So we're going to start with one that was coming in through the Q&A box from Elizabeth. So I'm just going to read it out loud, and then CoLab folks, if you just want to jump in to answer the questions, that would be great. So is there a foundational CBT Plus training available soon? I periodically see CBT Plus training circulate, but they're usually advanced or specialized, etc. And it's been a while since I've seen one for entry-level therapists. I've got a new hire. I'd like to get trained in this model, especially regarding PF-CBT.
I can jump in here unless my colleagues certainly invite anyone else to do that. So yeah, Elizabeth, you are not alone in this question. We hear this a lot from different organizations. And it just, there it is. Okay, so CBT Plus has typically done their foundational trainings October through February. And so, yes, it does create this difficulty for organizations and folks such as yourself who, you may get a new hire at various points. And what if you hire them in March and now you've got to wait till October? We've heard this. And I will tell you that right now we are, CBT Plus is looking at that to think about, is there a way to spread that out or to shift, to revamp some of the current ordering of trainings in that foundational CBT Plus to accommodate this very issue that you've highlighted. I also wanted to, this is not the subject of this webinar, but some projects that my colleagues from CoLab and I are working on have to do with how to address this issue around elevating internal organizational capacity and enhancing their capacity to kind of get their clinicians trained in CBT without having to sort of wait for this foundational training during those just select months. So I guess I would say stay tuned and definitely make sure that we keep you on sort of our whatever listserv we have where we sort of announce things, because we're working on that on a couple different levels to improve access to organizations to get their clinicians trained. So I think that's hopefully that answers your question, Elizabeth.
Great, thank you, Georgiana. So moving on to another question. So Kathleen had asked in the chat just around why were treatment goals not measurable and observable with a time frame, and then had also asked about the PIPPS format for progress notes. I don't know if you all wanted to expand on that at all on Kathleen's question.
And I think we don't see the question in the Q&A. Is it in the chat?
Yeah, it was in the chat. It was from a while up, so.
Oh, I think this would probably be for you to take, Georgiana, but basically the question is just, can there be a different format for progress notes and still continue to use that format of reporting EVPs, which.
Yeah, I answered, yes, I answered that. I don't know if Kathleen saw that.
Yeah.
But I had said yes, and it sounds like the domains are similar. And then I said I'm happy to talk offline individually to sort of provide some more help with that.
Great. And I think the first part of that too, Kathleen, hopefully that made sense. I typed in the chat as well that the section that Georgiana was covering was interventions and not goals. Because we also use things like SMARTY goals, like the acronym SMARTY. For our agency, there's other ways to do goals, particular to clients that CoLab is not regulated as part of this reporting guide. So they're not dictating what the goals have to look like. Those are going to be individualized for the client. But this was more about those interventions linked to the treatment modality. So that, yeah, hopefully that made sense.
Great, thank you. Just wanted to give space in case either of you wanted to expand on that at all. So thank you so much. So our next question, if a training entity is not listed in the report, and I'm assuming these are quarterly data reports, does that mean no agencies reported that entity in the quarter?
Yeah, that's correct.
And I would just add, Kiki, if you think there's agencies that are delivering that service and you're not seeing them show up, that's a great place for us to partner with you and then maybe help that organization kind of check whether they're actually reporting it, because it requires a couple offices usually within the agencies to be coordinating.
All right, thanks, Sarah. I'm hopping back and forth between Q&A and chat, trying not to miss any questions. So please let me know if I've missed something, but we're gonna go to our next question, which is in the Q&A box from Mary. So would it be possible for HCA to work with managed care organizations to include using the guide and EBP reporting and value-based care payment models? This would better align two major pressures Medicaid providers face: the drive toward investing in workflow that complies with the expectations of value-based contracting payments, and the drive to invest in workflow that encourages documentation of EBPs. It would be optimal if I could get credit for both while making the substantial investment required to take EBPs and encounter reporting to scale.
I'm happy to take that one. So Mary, not speaking at all for HCA, I can say that we've been working with a group that includes HCA and managed care organizations to develop out kind of a proposal for value-based care that includes reporting evidence-based practice as one metric within that, kind of within sort of a larger view around value-based care. We're expecting a practitioner-facing report to be available, around end of June, like kind of early summer. And we'll be bringing it also to the children's subcommittee to chat about. So that is a conversation that's happening. And so that would be great to follow up with you specifically about that as well, if you're interested.
Great, thank you, Sarah. So moving on to our next question, could you also talk about how some codes are training programs like the UW Master's Program, and some codes are specific manualized programs like COPE and CAP?
Do you want to take that one, Anna?
Sure, and I'll let you jump in.
Maybe training on evidence-based components was not a substantive difference. So we just think of COPE and CAT if they're providing training as a trainer, just like we think of the UW Master's Program as a trainer. So it just simplified things for us to think of everything that way.
All right, thanks, Sarah. Sorry, would have loved to take that. All right, so moving on. I'm curious about the CBT Plus notebook and how the handouts are created and updated.
I can jump in here. if you want to say more, Jennifer Wyatt, about if there were specific curiosities, I will say it's a free, accessible resource, and I am happy to put that in the chat or the Q&A. I'm happy to answer it live and put that link in there. It is I think a wonderful resource that has guidance for therapists. It has worksheets and handouts, as you noted, for clients, and just really a wealth of information to help clinicians, and I would say supervisors, to be able to support their clinicians in implementing CBT for anxiety, CBT for depression, CBT for trauma, and then behavioral parenting intervention. So those 4 models. How the handouts are created and updated, we love that CBT Plus. We work with clinicians all across the state who have just enormous wisdom. Many of them are probably on this call and are at your organization. And so we meaning the sort of the core CBT Plus team, we may learn about a handout or a resource that a clinician shares, and we say, gosh, that would be great to that would be great to put on the website. And so we do that. Sometimes we also, the core team creates resources that seem like they would be, there's a need for them based on our, sort of experiences. And so see that Jennifer added to that about the decisional balance. Certainly, Jennifer, I was also going to say, we're also a small team. And so we'd love to have like a dedicated person to, be updated. We try to do that, but duly noted that there may be some things that are sort of out of date. And if you have any, suggestions or thoughts, would be glad to take those offline.
Wonderful, thank you. So moving on to some of our other chat questions. So does HCA have standards for the percentage of services an agency provides that need to be EBPs?
Who do you think that should go to, Anna?
Probably you, if you have any thoughts on that.
Yeah, which question are we looking at again?
So does HCA have standards for the percentage of services an agency provides that need to be?
No, there are no benchmarks. There's just the requirement to report. And the requirement's really an MCO requirement. They have to demonstrate that they're encouraging reporting and that they're gathering those numbers. So then it's kind of MCOs have taken different approaches to encouraging reporting based on that. But there is no kind of benchmark. But per Mary Stone Smith's previous questions, there are other efforts sort of moving forward to think about how to create incentives for reporting and using the listed EBPs.
Great, thank you. And kind of a follow-up question that aligns with that one is, can we talk about how MCOs interact with this process? I don't know, Maggie, if you might want to share a little bit about that with the reporting.
Yeah, I mean, some of the ways in which I think it was a lot of back and forth between us and HCA and kind of finalizing how we receive the data, but a lot of, it predates me, so I can't give a lot of details as to how we came to, and I know some of it is coming from claims data and kind of, we were kind of working with them to get the kind of data that we were looking for. But Sarah, you probably would just have to give the more detailed response.
Be happy to. I'm realizing I'm distracting myself by typing. And so you could just repeat the question.
Yeah, so the question is just how are MCOs engaged in the EBP reporting process, and at kind of what points are they?
Oh yeah, the MCOs should be getting they're getting any EBP data that HCA is going to get. So if you feel like HCA is not getting it or MCOs aren't getting it, you know, we're happy to help troubleshoot the kind of the delivery line. But the MCOs provide that to the HCA. The HCA is collating it so that we can get it across payer type, and that's what's producing the reports that are on our website.
So it looks like we have, I'm not sure if you already answered this in the chat, Sarah, but we have another question from Mary. So we provide a substantial amount of clinical trainings internally for our staff. With the current workforce shortages, we need to coordinate all trainings internally to ensure they're available shortly after hire. This way, new clinicians lose less time in the field. Because our trainings are not approved, our services don't count, and we don't have time to submit every clinical training for approval. Is there an alternative to using only your approved trainers?
Well, so kind of the pathways here are either we can look at the training that are being conducted internally and compare them against the essential elements. It wouldn't necessarily need to take that much time. We just need to see the materials. So, you know, send them our way. We would do most of the time to review them. The other option is if you're largely using the materials like modular CBT, for example. Georgiana and Anna are heading up this embedded clinical coaching model. And that would allow us to basically list agencies as approved trainers so that you don't have to wait for training slots to open from external trainers, and potentially get support from CBT Plus. And, you know, over time, we would hope to add other trainers to kind of this approach to doing EBP training. But basically you could kind of support from kind of an external training organization, but your agency would be the approved trainer so that you can kind of manage the turnover in real time around the workforce and new training needs, et cetera. So right now, those are the two pathways. So I'd love to talk to you more about it.
Great, thank you, Sarah. And then another question, do the MCOs review people's training qualifications or visit documentation at all?
So I think if we're talking about the reporting guides, in terms of training qualifications, it's the EBPI that actually looks at training qualifications and ensuring that the trainers that are listed are you know, kind of are credible and are aligning with the essential elements of those practices. As far as I know, MCOs aren't really doing like independent like medical record review around the verification of EBP. That seems like that might happen if things start getting tied to value-based payments. So right now, that's not the case.
And I just wanted to add, I know that we just are in the process actually of updating our information of which EBPs our staff are trained into the MCO. So they are collecting it to some degree, but I also don't know that it's linked in any way to this process right now. But yeah, don't know what extent that goes to, for my end at least.
Great, thank you, Justin. So it looks like I'm finding one other question in the chat. So we report EBPs in our agency. How is HCA getting that data? They previously were not.
So we kind of addressed this a little bit before. The MCOs are getting the data from the agencies, and the MCOs are giving the data to HCA. So if it's not making its way through, there's kind of a breakdown that has to be resolved. We've been involved with a couple of the MCOs reconciling their data with HCA and kind of troubleshooting some of those data issues. So if you feel like it's not, so for example, like your counts are not coming out on the reports that we're providing, then we really want to hear from you, because every time we get to troubleshoot an issue, we learn something new about the system, and then we're able to kind of make those changes.
Thank you so much, Sarah. All right, so I'm looking at another question in the Q&A. So providing trainings internally is also essential for controlling costs. This organization has staff in clinical leadership positions who are currently providing trainings. And it sounds as if we need to submit training materials. A related question is whether or not the online EVP trainings count. So using Relias for some of these trainings.
So we are listing trainings that we know have an observation and feedback component. We feel like that's an important check, like a minimal check. It sounds like some agencies are going to have really strong supervision, or they're doing a lot of on-site coaching in those components. So if that's the case, what we'd actually really love to do is chat with your agency about whether we could think about moving that agency into an embedded clinical coaching model so that we know that that observation is happening on site. And I don't know, Georgiana, I know it's still evolving, but I know that's kind of one of the potential plans for embedded coaching. There'll be a lot more asynchronous training that can be happening kind of as needed. And then there's sort of the support to set up those kind of coaching and supervision practices within the agency. Did you want to say anything more about that?
No, I think you did a great job.
All right, so it looks like we have one more question in the chat. So if someone is trained in an EVP maybe years ago or in another state by an entity other than the approved trainers, can they still report use, or do they need to be retrained? So what I will say on that, and Sarah jump in, is as of right now, they do need to be listed within our guide. However, again, if you want to reach out to us, as Sarah mentioned, it's a pretty quick process in terms of evaluating trainings and ensuring that some basic clinical elements were met. So I would recommend reaching out to myself or to our team around whether or not that EVP, if we could list it or if it could count. But as of now, unfortunately, it is pretty limited, which is just how we monitor kind of quality of care.
And I would say getting trained out of state is not at all an issue. It's just sort of knowing who provided the training, what it was on, that it covered the essential elements is the key thing.
Exactly. Wonderful. Well, it looks like, please let us know if I missed any questions. I know there was a lot coming through and we're so grateful for so much engagement. So what we'll do now is I think we'll hang around if anyone has any questions that we missed, or if there's any other kind of feedback or thoughts you want to share with us as panelists, feel free to pop something into the chat. But otherwise, just want to say thank you so much for being here, and thank you so much for engaging with us around this kind of complex and ever evolving process around EVPs and addressing how they fit in with kind of broader understandings of quality of care. So thank you so much. We will hang around for a bit if we missed any questions. And again, please feel free to reach out to us, and hope you have a great weekend.